Good afternoon. Good afternoon, everybody, and welcome. Welcome to the 10th presentation in the Center for Innovation Thinking Differently speaker series. My name is Chris Ross, and I serve as Chief Information Officer for Mayo Clinic, and I have the special honor today to welcome you. We're really happy that you could join us. On a personal note, I'm really pleased to be able to speak on behalf of the Center for Innovation and its leadership. The CFI began this speaker series in our Transform Symposium events that are held in September every year with the acknowledgement that a thinking differently mindset and capability is essential in our quest for innovation and transforming the delivery and experience of health and health care. External thought leaders inspire us about what's possible, help us to think differently, and broaden our perspectives. So we are very, very fortunate that Mr. Frans van Houten, CEO of Royal Philips, is here to join us today to do just that. More on Mr. van Houten in just a moment. First, the format for the noon hour. It's going to feature a presentation on healthcare innovation in the cloud by Mr. van Houten, followed by questions from the audience. We ask that you wait until a microphone is brought to you so that we can get it audio recorded and heard remotely. Mr. van Houten will also be available after the session from 1 until about 1:30 to answer any additional questions. A little bit more about Mr. van Houten. Frans van Houten is CEO and Chairman of the Board of Management and the Executive Committee of Royal Philips. He started his career with the company in 1986. Subsequently held positions with the organization in Germany, in the Netherlands, and in Singapore, where he had responsibility for Asia Pacific, Middle East, and Africa. In 2002, he became co-CEO of the Consumer Electronics Division. In 2004, Mr. van Houten was appointed CEO of Philips Semiconductor. After that division was spun out of the parent corporation in 2006, he continued as CEO of the successor organization NCP Semiconductors until 2009. He rejoined Philips in late 2010 and led a project to separate ING Group's banking and insurance operations as an independent advisor to ING's management board. And then in April of 2011, Mr. van Houten assumed the position of Chief Executive Officer of Royal Philips. Since 2010, to October of 2010, Mr. van Houten is also a member of the European Roundtable of Industrialists. He was born in the Netherlands and holds a master's degree in economics and business management from Erasmus University in Rotterdam, the Netherlands. I had a chance to spend some time with Mr. van Houten and his team earlier today. They had a chance to tour some of our facilities, and I found the conversation absolutely fascinating. I know he's going to give us a number of insights around where the industry is going and potentially around some collaboration that we're already engaged in with Philips. So with that, I want to introduce Mr. Frans van Houten.
Thank you very much. Thank you very much for having me here. It's an honor to be able to speak at Mayo. For me, a magical name. So I'm as pleased maybe as you are to be here, and I think it underlines our joint partnership. Philips is a approximately $30 billion technology company, and we have recently taken the decision to change our portfolio and focus entirely on health technology. So we are in this together with you. I'd like to share some of my thoughts around innovation in healthcare and what would be the enablers to create a healthy future. In healthcare, it's our firm belief that the only way to innovate for industry, such as us, is to partner with people like you, people with deep clinical insights who share passion for innovation and also understand what it takes to actually change the world. Philips and Mayo Clinic have already a very collaborative relationship for many years. In fact, I heard maybe 30 years, which is, we need to be thankful for our predecessors for having had the wisdom to start this. And I believe it is because the founding fathers of both our organizations share the same views around the world and we share many of the same values. And that's fantastic. At Philips, we have as a value to put people at the center of everything we do. And we have a formulated mission statement that says we want to improve people's lives through meaningful innovation. Improve people's lives through meaningful innovation. And actually we measure that. And I found out this morning that you have a stated goal to touch the lives of, was it Barb, 200 million people. We have a stated goal to touch the lives of 3 billion people by the year 2025. And then I know everybody starts asking, and where are you then today? 1.8 billion every year. So we have a good reach in the world. There's a saying in this country that I think everybody is familiar with. That is, when you've got your health, you've got just about everything. And how true is that? And I think it is at the core that everybody wants. So health is a fundamental truth in any language. It's of course discerning to observe that people are not always motivated about their health despite that saying. They only are motivated about their health when it is a little bit too late. So we need to find out how to influence health across the entire population. And it is widely accepted that good healthcare and education are very important economic drivers to make the world more prosperous and also more peaceful. The challenge for all of us today is actually how to enable and motivate people to be healthy and how to deliver high quality, affordable healthcare to everybody who needs it. And that against the backdrop of mega trends where we know that there is an increasing cost of treating an aging population with an associated massive rise in chronic disease, a shortage of qualified health workers, and strained health systems in both developed and in developing nations. At the same time, we see these societal trends of developing nations also in countries like China, where aging is going to be prevalent and is a big concern to the government. India, the Middle East, Africa. So we need new ways of delivering care in order to have a good future. And it is our conviction, I think it is also yours, that current healthcare delivery models are not necessarily sustainable and also not scalable to all the people that need it. So new ways of care delivery are required, as well as a fundamentally different mindset in how we look at care. We all know that current reimbursement systems are largely based on the perception of cost. These reimbursement systems may be inadequate to actually stimulate optimization of care or the value of healthcare as an economic driver for society. But we are all locked into past practices, and to change past practices, you all know how difficult that is. That requires deep change management. We believe that healthcare should not be seen only as cost, but rather as an investment. So not as cost to minimize, but rather as an investment to optimize. And maybe that requires shifting of budgets from one part of the health continuum to another part of the health continuum. And maybe there needs to be a shift from focus on acute care and late stage interventions to prevention. Today we generally start to treat disease only when the patient goes to his or her doctor to report serious symptoms. And maybe that's a little bit too late. So next to symptomatic patients, we think that we can actually engage faster and earlier with healthy consumers to keep them healthy, as well as to support people to cope with a chronic medical condition at home and to avoid deterioration or escalations of situations. Now in Philips we have both a consumer business and a health care business, and I said already in the beginning that we bring that together and focus on it. And you see here on the picture what we call the health continuum. Consumers become patients, but they stay consumers. And we really need to put people at the center of care delivery. Traditional healthcare systems actually typically adopt a fragmented approach to diagnosis and treatment, with the process optimized around events or specific specialisms rather than how the patient goes through this end-to-end flow. Much of the resources go to acute care. In other words, we have today an event-driven approach versus a patient-centric or population health management approach. And change is not easy. Change will not only be driven by healthcare authorities and healthcare providers. Change will also have to be driven by consumers themselves, who are the patients to treat. They will have to take more accountability for their own health. And we often say we need to measure, manage, and motivate. And much of that is also behavioral in nature in order to reach the people and get them engaged on their own health. And we think that can only be achieved when we talk about the consumerization of care and going deeply in understanding what drives people. Now maybe there's some ambiguity in the word consumerization because that is not always a positive connotation. But what I try to say is that consumers and patients need to make conscious choices when it comes to issues surrounding their everyday health. And we believe that they will do that better if they are confronted with the right stimuli that surround their lives. Stimuli that will discourage them from doing certain things or encourage them to do other things. And that's, of course, very important. Change into a healthy lifestyle with the right sports, with lifestyle changes, the right nutrition. An apple a day keeps the doctor away, isn't it? But also medication adherence and compliance will have far-reaching effects than only the medical inventions in an acute situations. We do, of course, see that the dialogue around health care reimbursement has started around accountable care, and not just in the United States. This is happening all over the world. And people are struggling with how do we change the system. And change is needed as we need to move from a volume-based model towards more of an outcome-based model, where the reward is on the result rather than on the effort. Unfortunately, current changes still fall short of the mark because they are often just rate cuts, pressure on cost, rather than enabling change. And in order to manage along this health continuum, maybe money flows will have to shift from one phase to another phase in order to optimize the overall ecosystem. There's much promise in what we call population health management, with care providers incentivized to manage the health of the population and not just the acute patients that seek care. That can help prevent costly escalations. But it's not easy. I was speaking with the Singapore government the other day, where patients always flock to the emergency room because they get the best care. But that's 3 times as expensive as going to your general practitioner. So how to change that behavior? It will require a very effective coordination of preventative, acute and chronic care. In fact, we need to make care patient-centric and get under the skin of consumer behavior, instead of purely the technical side. Now, I wholeheartedly share Mayo's vision of always be there for me. Like Mayo, we think that we can provide a better experience for patients and therefore better health outcomes with greater patient comfort and lower cost if we move from a relationship on incidence towards a much more continuous relationship with patients. A continuous relationship which actually technically will become possible because of the internet and because of digital. The Philips model is continuous care across the whole health continuum, from healthy living, disease prevention, diagnosis, treatment, and eventually to provide care at home, following the life of people, following the life of patients, and using all sorts of data and interventions to support the health continuum model, where we monitor, track, and support the health of individual patients across care settings, caregivers, and even across their entire lifetime. Now, this is a very esoteric picture that, in fact, follows the person along his life cycle, and where data will play a very, very important role in the future, enabling better coordinated care, the better optimization of resources, and connecting the stakeholders across the whole health continuum in a meaningful way. But it will require that stakeholders and providers have access to the relevant patient information in order to support and maintain the patient's health and take the right decisions at the right time. To do this, actually most of the digital technologies to enable that exist today. And you may look at me quizzically and say, is that true? But many of these technologies are already being used in other industries. Take, for example, the banking industry. We all use self-service banking. We all use cloud-based services for our financial transactions as a matter of course. But the flip side is that banks can also assess your financial health at any moment in time. In fact, even predict your shopping behavior, even predict whether your credit card is stolen, because the behavior changes. This is all done, of course, using big data and data analytics and predictive algorithms and so on and so on. And we worry maybe what Google knows about us, it will be a great deal. Why don't we apply some of these technologies to healthcare a little bit faster and become a little bit less conservative? I think we could do wonderful things in this world. Mobile devices and mobile communications will also enable this and trigger a lot of innovation in consumer health. But we need to be careful that it doesn't become gadgets, because gadgets are typically discarded after a few months. So this is not about adopting gadgets. A patient-centric view of care follows disease and disease patterns and is deeply linked to clinical insights and not just to technology. The Internet of Things will give rise to connected sensor networks. Big data and cloud-based solutions will hold the promise to discover new insights through advanced data mining, easily sharing information, and also enhance collaboration. In fact, the rise of the quantified self will happen, and that will improve personal health and well-being for sure. The challenge is, of course, not in the technology itself. It will be in the adoption of meaningful technologies. And adoption is prevented by old habits. And to change old habits, we need change management. So it is about working closely together with all the stakeholders in order to come to a meaningful innovation. And that can only be done when industry and institutions like yourself closely work together. And that will improve patients' outcome, productivity, and cost. I would like to give you just a few examples of where cloud-based innovations can have a significant impact on health. Philips is not only active in professional healthcare, but we are also involved in consumer health. And I already alluded to the fact how important it is to get under the skin of the consumer. We have natural touch points with consumers in a couple of areas. Let's just look at three. First, the bedroom, where of course sleep is very important to consumer health. In the bedroom we have technology that we can weave into the bed sheets or into the pillow to measure body movements, breathing, heartbeat patterns, sweating, temperature. By applying algorithms to this, sleep patterns can be monitored as a matter of course. And personalized guidance can be given for those in order to get a better night's sleep. A second room in the house. Let's talk about the bathroom. In fact, we own the bathroom as Philips because many consumers have multiple devices from us. In the bathroom, our products are being used in daily rituals. Actually, the rituals are important because rituals can be used and extended for other purposes. Daily rituals such as weight management, oral care, personal hygiene. Our electrical toothbrush for kids is nowadays connected to the internet, and we use online interactive games to engage kids in better brushing with the right amount of time. This is called gamification. And gamification can influence behavior better than the wise words of all of us in this room. And it will not stop there. The brush can contain sensors. The sensors can help you through the brushing process, detect plaque, talk about the cleanliness of your teeth, can coach you on the brushing technique, but it could actually even inform the dentist how well you do. I'm not sure that we want to go there, but it would be possible. On a serious note, of course, oral health is actually connected to cardiovascular disease. And that to illustrate my point that bathroom rituals will be crucial to population health. This will also be the place where people take their medication and where we can maybe measure compliance better. It's the private space where the day starts and where we can have a dialogue around health with individuals. And actually I'm convinced that what we call the quantified self will actually start in the bathroom. Let's talk about another room in the house, the kitchen. Here is also a clear link to personal health. Smart kitchen appliances can coach people to eat more healthy food. It's actually amazing to know how few people have fantasy around the food they prepare. They really struggle with that. So prompting them and coaching them on food behavior can actually be both appreciated by consumers and have an effect on population health. Personalized recipes can help avoid allergic reactions, and taking it a step further, obviously help avoid high cholesterol levels. Data can be shared with a coach, and that can help dietary compliance. Let's move away from the Western world and all these nice rooms and talk a little bit about rural areas in the world. Mother and child issues are still very prevalent in both Africa, Indonesia, and other rural areas. And as we move along the health continuum and talk more about prevention, we are applying digital technologies to facilitate preventative care in countries with inadequate healthcare systems. Because we want to touch the lives of people, and we said, how do we do that in developing markets, where there are no clinics in the rural areas? Infant mortality is such an issue that we said we want to tackle. And then, of course, you realize that actually also in developing markets, 96% of the population has access to mobile phones. And these mobile phones can be used in order to link people to expertise in the medical side. We are applying this approach to maternal care in rural areas, for example, in Indonesia. Mortality risk there is still very high. Complications are often not recognized in time, and when they are recognized, it's too late to travel to a clinic where it can be helped. We have put in place mobile applications to monitor pregnant women and to identify those that are at risk through simple checklists and questionnaires. And with this dedicated software app, midwives can build a detailed health profile and by collecting data and then timely say, okay, you, mom, you have to travel to a nearby clinic. So we integrate local risk scoring guides, and obstetricians can remotely determine if the pregnancy is at high risk. In Africa, we are researching a different concept. We wanted very much to bring ultrasound scanners into rural areas, only to find out, of course, that there are no trained people to use them and or to read the image. We are now using mobile scanners in the form of a tablet with a probe connected, and where the processing is done in the cloud, the image is uploaded, and in a nearby city the image is interpreted, and then guidance is given through the cell phone to the local nurse, whether the child is fine or, let's say, the mother needs to travel to the nearby city. Nearby city could be, 3 days walking away, of course, from the location of the rural clinic. We believe that these are helping breakthroughs in countries where child mortality is still around 6-7%. If we move towards diagnostics and treatment in our health continuum, there we are applying digital technologies to diagnostics and treatment of complex and life-threatening diseases, such as, for example, cancer, which can only be provided in highly specialized environments. No other area of care, in fact, is as multidisciplinary as cancer care, and it will require many different specialists and departments being involved. Information needs to flow from the different diagnostic disciplines and decision makers in order to come to the right treatment plan. And in fact, we all understand that this will become more and more personalized as the only way to treat cancer in an appropriate way. And it is very important that we integrate all the sources of data. A one-size-fits-all approach may not work anymore. So we see the need for integrated diagnostics, combining insights from molecular imaging, digital pathology, genomics, with health studies to come to more predictive treatment pathways. And I'm convinced that smart digital integration of the relevant information will give rise to personalized treatment plans. But then we should also take the step of monitoring the effectiveness of such a personalized treatment plan and follow the patient at home, maybe through white blood cell count measurement, in order to see whether the patient is reacting and to the treatment in the way we had hoped for. And then close the loop in a closed measurement system where we can all take accountability for the result of the treatment. So we believe in closed loop diagnostics to determine whether the chosen treatment pathway is actually delivering results. And that brings us right back to the bathroom and the quantified self. So the goal is for patients to use technology in order to live a healthier life, but supervised by healthcare professionals to measure the effect of treatment and adjust treatment in an appropriate way. So we are not advocating at all a world of gadgetry, but rather a world where technology enables an integrated care pathway where the responsibility is still held, of course, by the care providers. In this world, I also foresee an increased collaboration with pharmaceutical companies. Actually, I think it's in their interest. As they are interested in personalized medicine, they will need to prove that the medicine is effective. And I think they will have a great deal of interest to participate in closed-loop measurement systems to unlock the promise of personalized medicine. Of course, in cancer care, we should not only talk about the technical side of it. Involving the patient is so important. And we need to think about how the dialogue can be brought back to the patient instead of to the technical side of the diagnostics. And have a dialogue with the patient when they are, for example, confronted with prostate cancer. Can happen to me as a man in an age at risk. And then choosing which treatment plan are we going to have is quite important because it may have all sorts of effect on my health. So having a good dialogue in bringing together data to the patient experience, enabling the doctor to have a meaningful dialogue will also be very important. And we believe that digital means can really help do that. As we move from treatment into recovery and back to the home, along our continuum of care, I'd like to share with you a final example on how we can apply digital technologies for patients and consumers in the home and support people with a chronic condition, such as heart failure, to live with that condition. And maybe we'll have to live with that condition for 20 or 30 years as we all become older. The purpose here is to detect early deterioration so that doctors can actually stabilize the patient's condition and maybe adjust the level of medication. This is not only helping avoid the need for hospitalization, but it can also increase the patient's quality of life. My own mother last year had 3 TIAs, and she was not taking her medication appropriately. And by fixing it, actually now she is happy and very active again. So it just shows how much impact it can have on patients, on people, and the quality of their lives. Connecting the weight scale in the bathroom, devices like blood pressure monitors, wearable sensors, but also checking medication compliance, such as in the case of my mother, can really help improve the quality of life. Uploading that data through the cloud and applying the right filters and algorithms makes it also then manageable for care providers to deal with a larger population on a continuous basis. Advanced algorithms can filter and monitor and provide trend lines in order to make this digestible. Clinicians are provided in such a world with a regular review of patients, allowing them to prioritize patients and adjust care plans or intervene as needed. The applications will give clinicians the real-time access to both objective health data, such as vital signs, blood pressure and weight, but also the subjective responses via questionnaires and checklists, or maybe how much did the patient actually move around, or were they just sitting still and becoming stagnant. We also believe that besides giving the clinicians access to data, we should give the patients access to data. The Veterans Administration, of course, has done that by giving vets access to their own data. But by giving patients access to data, we believe we can give them the stimuli to change their behavior. Personalized data can be accessed through a tablet. It allows patients to answer questions about their health, but maybe also to watch a video about what to do next and how to change their lifestyle. They can stay connected to care providers and receive coaching. The application will remind them about pre-assigned tasks, such as taking medication. So all in all, ladies and gentlemen, I've given a number of examples of how cloud-based health care innovations can make a difference. I'm convinced that convergence of consumer technologies will facilitate healthy living. Medical technologies will help clinicians deliver better treatment, and cloud-based technologies will help the data sharing and the collaboration between all the care providers. And that brings me to a related topic. Digitization of healthcare also provides opportunities to standardize the care process. Standardization is very important to deliver quality, to increase transparency, and to create feedback loops to allow continuous improvement. That will help us make care more personal, more effective, but also more affordable. In fact, what I'm describing here are proven techniques in the industry. And therefore, I talk about the industrialization of healthcare. That may sound a little bit tough and cold, but actually it's needed for healthcare to scale, to deal with that large and growing population from 7 to 9 billion people and an aging population that needs to deal with more chronic disease. So I'm talking about applying industrial concepts such as Lean Six Sigma, integrating workflows and enabling, but also forcing and measuring collaboration across departmental silos. Lean Six Sigma is a method to continuously improve workflows in a structured manner by eliminating waste. Waste such as waiting times and waiting times can be both patients as well as care providers. Waste such as overproduction, in other words, first time right instead of repetition. And I think we can see in many areas very meaningful results through the application of Lean Six Sigma in healthcare to create a feedback loop and optimize care pathways. Kirkland Clinic in Virginia, Mason Medical Center, has applied Lean principles, and they have no waiting rooms at all anymore. They also achieve better utilization of the expensive facilities. During the day, doctors and nurses are actually supported by medical assistants when providing care. Now, the role of these medical assistants is actually one of a process manager, of a process facilitator. And they lead and ensure that all the care processes run seamlessly and are well connected and smoothly. Now, this may sound like extra cost, but actually it reduces waste and thereby allow all the specialists to do their work in a better way. Another example where we have developed a service to remotely measure and analyze the usage of imaging equipment in radiology departments. As part of that service, we monitor how the equipment is used. For example, by tracking the applied X-ray radiation dose to obtain the medical image and offering advice how to advance safety. We map unused capacity. We provide suggestions on workflows and capacity utilization. If you have a radiology department of maybe 100 radiologists, how do you know that everybody is at the same level of competence and effectiveness? Right? This is all measurable, and through Lean Six Sigma methods, we can then coach everybody to get on a higher standard. In a hospital in the Netherlands, we were able to reduce waiting times on MRI in that context by more than 80%. Ladies and gentlemen, allow me then to conclude and bring it to ourselves around this great partnership between Mayo and Philips. We share Mayo's vision that the complexities of modern healthcare and the associated vast amount of knowledge can only be assessed by cooperation and open collaborative innovation. And it is vitally important that we bring people together, such as in this picture, to gain insights and ensure that what we innovate is locally, culturally, and clinically relevant and usable. We don't believe in a copy-paste approach as such, because complexities are different by country, by situation, but we do believe in continuous improvement and the use of know-how, and learn from each other's best practices. We can learn from each other through, multidisciplinary fashion. And if we all embrace innovation ecosystems, where private sector works closely with academia, supported by government organizations, we may actually achieve in changing the healthcare system altogether. Where hopefully, expectedly, let's be positive, reimbursement models will also change towards rewarding outcomes and providing incentives for innovation, such as the optimization of total cost per patient along the health continuum. And that, I think, will be great for all of us. But it will require us to rethink our engagement model together, to rethink it from the traditional model of a supplier-customer relationship, a vendor-vendee relationship, towards a shared accountability model. And with more and more of our customers, we are shifting to the right-hand side of this picture, where we can have common goals, where we can have shared risk, where we are rewarded only when you are successful, and where we are jointly committed to quality, efficiency, and cost and better outcomes for patients. I think that would be pretty cool if we can do that. I think we have many great research collaborations already, and we would love to take this to the next level. We are doing this new model already with some 40 large IDNs in the world, and I think it totally changes the relationship and will have much better outcomes. And we will be able to leverage resources together in a better way. Thank you so much for being here and to hearing me on this vision of the world and where technology is coming. And thank you for your great collaboration. With that, thank you very much. With that, I'd like to give you a chance to give any comment or question that I can then answer.
Well, thank you very much for that interesting presentation. The last slide is of particular interest to many of us because the relationships that we've had with companies like Philips, not just Philips, over the years has been almost exclusively a vendor-vendee relationship. So to the extent that you're in the position to expand on the new model and how that actually works with the 40 or so organizations that you're piloting it in, it would be of interest to us to hear a little bit more about it. I suspect you're talking with Barb and Doug about that, but to the extent that you could share that more globally with the audience, I think that would be useful.
Yeah, no, absolutely. And we would love to bring some insight in these case studies to Mayo and then to jointly explore it. If I just make two comments about it, one is, as a customer, what question do you ask your supplier, right? It's one thing to say, I want to buy a chair. It's another thing to say, can you solve this problem? So I think the right question needs to be asked. For example, Karolinska Hospital in Stockholm asked us the question, can you help us treat a stroke patient within 90 minutes after dialing 911? Now that's a great question. They didn't say, ship us a CT scanner, right? Which eventually we did. But in this case, In this case, we worked out the pathway of care, triaging in the ambulance, sending immediately the data to the hybrid operating room, bypassing the EMR, the emergency room, and bringing the patient directly to take the blood clot out. And so we worked together on white walls, put the value stream there, workshopped around where is time lost, where is the bottlenecks, and you come to then a different outcome. In that context, we act as a consultancy company and not just as a supplier. Another point is that we need to change our attitude towards payment, right? Where we are able to say, actually, you only pay us on results. Yeah? Or you have a hybrid model for something like that. So then the incentives and the behavior of my people will be aligned with your people, and together it becomes teamwork, and it changes the atmosphere totally. So we'd love to go deeper and share some examples, or maybe even bring some of our other customers in to provide their experience to you.
Frans, one example that you might speak about was the AWARE project and the collaboration that's going on there. I think that speaks more specifically to Nick's question.
I'm deeply impressed with what you're doing here at Mayo. And I think I said in the corridor, it's both visionary and practical, which is just beautiful, right? It's a deep commitment to, let's say, the clinical practice, and at the same time embracing technology. And I think our collaboration in the AWARE space, I think has an enormous potential. And we would just see how we can scale the know-how of Mayo and make it accessible to other places in the world, and thereby by upgrading the standard of care in the world. So I think this is a prototype of how a partnership needs to happen. I'm deeply thankful for that partnership. All the way on the other side of the room, maybe for the next question. Yeah.
I'll just make a quick comment. I oversee the medical supply businesses here at Mayo, which includes the CPAP business, and we're using your technology to use the cloud to monitor compliance in patients. And many of you may or may not know that the NTSB requires all truck drivers, pilots, train engineers, et cetera, anybody in the transportation industry to be tested for sleep apnea, and if they have it, to comply. And so this is an easy way for us to be able to, with the cloud, report back to patients on their compliance. Their physicians can be involved in that, and they can provide that data to their employer to continue their employment. So it's a great way for us to use that technology. Thank you, and a great example of integration. And I think integration along the use cases is the solution. So thank you very much for that, and I appreciate it.
So thanks for the presentation. This technology has been around for quite a while, and the CFI and Mayo has been using it. And in the interview with Dr. Noseworthy and Charlie Rose, Dr. Noseworthy said, the biggest hurdle, the technology's there, but the biggest hurdle is reimbursement. How do you see us getting past that hurdle with reimbursing for these services?
I believe that any problem starts by giving insight. So I think we will have to engage with policymakers to give them the insight in where the current system constrains us in the wrong way. And then, let's say, take people on that journey. Now that may sound easy. I'm not close enough to the US system, but I know that in my own country, we have put the insurance companies, government, and providers all together around one table and started to give insight in use cases with data to prove the point. And I see insurance companies starting to shift and starting to move towards redirecting money streams to those interventions and technologies that actually prevent costs down the road. This may be a long journey, but still it's a journey that we need to take together. And I think with your thought leadership, you would actually be in a good position to say, you know what, this dialogue needs to be held. And then if we all team up and support, we can probably make it so data-driven that there's no argument against it. Now, I know that in politics there are other factors at play, but I still think we should try that. And because in the end, something needs to change, and if nobody stands up to change it, it will never happen. But that's an optimistic view of the world.
You mentioned the value of standardization, and of course that's driven towards quality, how we make sure we have optimal quality. In your process of getting standardized across different systems, if you're doing that, one of the potential values there is to have the ability to benchmark and to have different organizations then benchmark and be able to say, if you're going to standardize, and how are we doing on a global level or a regional level? Have any of your systems touched on that yet?
Yeah, and it is, of course, in an ideal world where you have a lot of data, you can make that happen much easier. I don't think we are totally there yet, but in pockets we are. And we have established an in-house consultancy practice to make it their job to unlock best practices from other hospitals or other countries and make that accessible still today in workshop style. We have started to data mine the vast amount of metadata under our management, metadata around imaging studies or respiratory devices, as earlier mentioned, and to unlock that value. And there's now an increased interest in that. I must say 5 years ago that interest was minimal, but people start to realize with the cost pressure that benchmarking is very important. But the first reaction is often defensive. Right? Because, oh, we are already doing it very well, or we have tried everything. Right? It's interesting that in our consulting practice, we attract quite a lot of people from McKinsey and Accenture and so on, because they believe in our more output-orientated business model. Instead of just doing a study and then nothing changes, we go further and say we will actually work with you to implement the change in the clinical practice. So data, starts to become available in a more ubiquitous way. But also there, I think we could do a lot more together. Yeah, there's somebody behind you with a microphone.
Hi. So there may be two major trends in healthcare now, not the only ones, but one is the push for the standardization that you just touched on, and the other one is the push for precision medicine and individualization. And it appears to be like a centripetal, centrifugal kind of forces working at the same time. And I was wondering what your thoughts are on the tension, and if you see the tension there just going further into the standardization, but then how do you make sure that actually it's not compromising the individual needs of a certain person?
Yeah, that's a great question. Actually, I don't think that tension is there. Tension is only there when standardization is misunderstood. So Lean Six Sigma doesn't standardize for the sake of standardization. Lean starts by putting the customer at the center point. And then say, what is the leanest path between me and my customer? And if you take the customer or the patient in this case as the center point of Lean and Six Sigma, then you would not fall in the trap of saying, well, standardization, and if you don't use it, then too bad for you. So I think personalized medicine and standardization can go hand in hand. The standardization very much applies to the practices and the workflows, not necessarily to the treatment plan for the patient. Now, I'm not a doctor, so I'm translating, let's say, or extrapolating industry practice to your practice, and I should not get too much on that slippery slope. But let's say standardization is not at odds with a customer-centric view at all, in my view.
Thank you for such a great presentation, Frans. So, we've been on a journey of innovation for 150 years. In fact, it's our sesquicentennial. And, you're aware that we really sort of stepped up that commitment with our Center for Innovation and opened our doors 6 years ago around this whole idea of how do we bring, design thinking, understanding the user needs as we build out product and service. So, we're constantly thinking about, the portfolio of innovation around health and healthcare, this idea of how we innovate around the core and how we think about emerging businesses and such. So I'd love to just hear a few more insights on how you might advise us as we continue the journey of innovation. So how you've been thinking about positioning innovation in a large, complex organization and any advice you might have for Mayo Clinic.
Well, I don't want to be presumptuous, but innovation is often driven by a few inspired people, and then the rest follows. Now that can lead to a very anarchistic environment. So in Philips, we first say here is the overall vision where we want to go, and then we inspire people to think about the unmet needs in our case, the health continuum, to say, what can you contribute to making that more effective. We have compartmentalized groups to focus on certain stages of the health continuum. For example, we have just a year ago set up a business around personal health in the preventative phase, and said, look deeply at the unmet needs in that space, and make it specific to disease types, because we don't want to boil the ocean with a gadget. And they came up with a number of very interesting propositions around obesitas and diabetes, but also, for example, around lower back pain. Lower back pain is causing a lot of workplace productivity loss. Insurers pay for that, employers don't like it, and the patient also hates it. Now, how do you intervene in lower back pain timely? And actually this group innovated together with Allianz, the insurer, to have low muscular stimulus with a pad with blue light and a coaching program, which is being provisioned through the employer. And the insurance company has redirected money to it. So this is kind of an innovation that required multiple parties to come together to address a very specific issue that was large enough, let's say, to make a business out of it. In this case, I think we find people to innovate around real needs and real problems. So it didn't start as a technology question. It started as a need question in the medical, let's say, in the life of people, in the life of patients. And your commitment to innovation with the living lab approach is fantastic in my view. And the better we collaborate on it, so your wellness lab that I hope we'll hear something more about this afternoon, would be great, because I think it fits on the more consumer side of the health continuum. And we fundamentally believe that our businesses need to build on clinical proof points. If we don't, we actually will not have a business that is as sustainable as it needs to be. Because anybody can make a gadget, but if it is deeply anchored on clinical insights and together we can create a business model around it that is sustainable, we actually, I think we build a business that is good. So as we innovate, we try always to think about the business model at the same time. Well, thank you very much. I really appreciate your attendance. Great discussion. Thank you. Thank you.